Hi, I'm Dr. Michael Abernathy.
And I'm Steve Hoyle.
Okay, and you work for Bayshore Dental.
I am a certified dental technician. I work for Bayshore Dental Studio, yes sir.
Okay, now I wanted to kind of grab you when nobody else was around because, you know, a lot of times we film things and it's the ideal crown and the ideal impression, and that's not the real world. I was a lab technician for 6 years before I became a dentist, 3 years while I was becoming a dentist, and we've always had a dental lab in my office. And so I'm real aware of some of these challenges too, but I'd like, since things have changed, I'd like you to tell me kind of some of the top things that you run up against, because I realize that you don't know what we had to go through to make the impression, but this is a partnership. I mean, I got to do my part, you got to do your part. If I don't do my part, you can't give me the restoration that I was hoping for, but it was my fault, okay? So tell me what you see. Tell me what happened.
Well, you're right, Dr. Abernathy. We're certainly a team. And as far as bridge work goes, one of the biggest things is a parallel challenge that we have. I mean, it's huge. And I've been in this business for over, well, I hate to say it, but about 40 years.
Okay.
And 40 years ago, we didn't have these problems. Of course, dentistry wasn't, you know, it wasn't done as much, especially fixed work. Right. And it was limited to the PFMs and the gold crowns. Right. Now we're in the digital world. Things are much more sensitive. But what I see is a lot of undercuts on bridge work. We have to call on, I want to say 40% of the cases are going to have a challenge.
Okay.
And that's just what we see here.
Okay. So now on, when you say there's an undercut, in other words, the abutments aren't parallel, one's tipped over, so that creates this huge undercut here. Or in prepping it, they've created an undercut.
Exactly,
and it's not going to draw.
Exactly, that's correct.
Okay.
And we do see a lot of tilted crowns or preps and stuff.
Right.
And also, a lot of these preps don't have the 3 to 4 degrees of taper that we need to get a good path of insertion. So even on a single unit, sometimes we can get an undercut because those axial walls are actually 90 degrees, and like you say, when they marginate, sometimes they go into an undercut.
Right. Okay. So we can probably help with that. I know when I look at a bridge, if I take my mouth mirror and put it over the back tooth and look at it, and I turn it finally where I can see all the margin, and I move it forward, if I can't see the margin, it's undercut. It's undercut every time if I do that, and I can't see that margin. So I'll go back and do it again. Maybe I moved it, and I do it a couple of times, and you can't see it. And I'm not suggesting you TP it, but we may have to take that side and bring it in enough that the bridge will draw, okay?
Yeah, and you've got the patient there, so that'd be a great thing. I mean, you know, versus having to make adjustments to the prep itself, and then you just kind of biting your nails, if you will, when you go chairside to seat that.
Yeah, that prep and pray doesn't work all that well.
It does.
So I see dentists, and again, I'm speaking of my own experience. These were actually dental professors sometimes that would send me something that I couldn't work with. It was frustrating because I wanted to impress them what I could do, but it also was frustrating that they made it impossible for me. So when we look at crown and bridges, say it really is a partnership, and my responsibility is to give you something you can work with. So as we're talking about the problems you see, I want to make sure we kind of touch on things that could actually help fix that. So one, on the undercut, I see people use too short of a burr so that it creates gouges as they're going down, rather than using one that's like a KS2 or KS1 that's probably, I don't know, 5 or 6 millimeters long. So I can touch from my finish line all the way top, all the way around, create a nice smooth surface for you.
Here, when we're making provisionals, that is exactly the burr that we use here in the lab.
Okay, great, super,
super. And I know exactly what you're talking about.
Okay. So just picking the right burr can make a big difference.
Absolutely.
Taking the time to go back and look. It always seems like we have time to redo it. We don't have time to do it right the first time.
That costs everybody money, doesn't it?
It does. I mean, and it's embarrassing for you because you've got to talk to the doctor.
Right.
But you also have a business relationship. If you talk to them too often, you're afraid they're going to take their business elsewhere. But your reputation and what you do is important to you, and our reputation be important to us too. So it's a partnership.
It absolutely is.
What else do you see?
Well, occlusal clearance challenges are probably the next big issue. I mean, it's huge. I just got off the phone downstairs talking to a client, It was 18 and 30.
Okay.
And 18 was opposing a gold crown, and we probably had maybe 0.2 of a millimeter.
Right. Okay. Okay.
And you could hold the bite up and see where the patient had pretty much perforated the bite. Okay. And the doctor told me, the doctor was nice and everything, and said, you know, the patient just came in and was having problems with that provision.
Okay.
And I said, well, I can see why. And we discussed how to move forward. Doctor wanted a reduction coping because it's opposing that gold crown.
Right.
Well, here we are. I mean, we're reducing the clinical height of the already short prep itself, but, you know, we're going to do that. But here again, you know, that's a challenge.
Okay. Now, from a dental standpoint, the ideal height of a prepped tooth is a minimum of 4 millimeters.
Right.
Okay. And on a second molar, with the retromolar pad coming down, oftentimes we'll have like 2 millimeters on one side and 4 on the other. It's already difficult back there.
It is.
So now it becomes even more important to have only a 5 or 8 degree off vertical axial walls all the way around. Everything perfect, impressions perfect, cord pack, margins, everything has to be perfect there. Okay, so occlusal adjustment. Let's talk about this. I mean, I grew up in a world of McLean twin foil, all porcelain units back in the early 70s. We didn't have cement that would work to do that. But most of it was porcelain veneered to a metal. Now, we're talking more crowns now that are Emax and certain type of zirconium, correct?
Absolutely, yes.
Okay. One of the frustrating things I see about zirconium crowns is that they're harder than heck. I mean, you can take a hammer and drive them into a countertop and they won't break.
Absolutely.
But you can't abuse them. And so what would ideally would you want for occlusal reduction for a zirconium?
At least a little more than a half a millimeter.
Okay.
And we have to have virtual die spacer here, so we're going to have to probably have 100 microns there, which is about 1/10 of a millimeter. And then the minimum any manufacturer suggests is a half a millimeter. So we're talking 6/10 of a millimeter minimum.
Okay.
Minimum. And then if that's a heavy bruxer, then we're in jeopardy here. You know, we really would like a millimeter, but I know sometimes it just can't happen.
Okay. Now, again, I've got to think though. I went back and actually Googled the manufacturer of zirconium.
Okay.
And they said they wanted 1.5 millimeters for occlusal reduction on a zirconium. Now, this is like old amalgam fillings. You know, amalgam fillings you could hook shot from the corner room in a wet mouth and they'd do okay for a while.
Right.
So it got you where you really got lazy about the quality of dentistry you did. I mean, and I'm telling you guys right now, if you're a dentist or something, you need 1 millimeter to 1.5 millimeter reduction on zirconium. You need 2 millimeters reduction on Emax. Zirconium, we need at least 1 millimeter on the axial walls, and we need a deep chamfer at the margin, not a feather prep. And so while you could make a crown that would fit a feather prep, now we're compromising the material we've chosen. The doctor's compromising the quality of prep, the retention, and the longevity of the crown they're placing. And so, again, this is not the place to skimp. You know, just because you can get away with it a couple of times,
right?
You know, he really needs 1.5 millimeter occlusal reduction. And again, if we don't want a flat top, if it looked more like the shape of the tooth, you can still get 1.5 millimeter in the central fossa. You can get it on the cusp tips because it's fitting into the occlusal, you know, at the top, and we're all okay.
Well, it's just like you said there, the more we got, the better it is, of course. And you're right. I mean, do we do them less than that? Certainly we do in certain circumstances. But it is, like you said, it's a little scary. Is it going to succeed? Maybe. But if we have 1 millimeter to 1.5 millimeters, like you just suggested, then that's pretty much a no-brainer.
Yeah, so it's a hook shot from the corner of the room. And the same thing, if you're still using a porcelain veneer to a metal, lava crown, porcelain veneer to a zirconium or a disilicate, thimble, again, those still need 1.5 millimeter to 2 millimeters reduction on occlusal. They just will fail long term.
Absolutely, they will.
Okay.
The lithium disilicate or the Emax is a strong product, but when you get under 1.5 millimeters, then you really start losing.
Yeah, exactly. You know, and again, this monolithic block of zirconium or disilicate can be somewhere between anywhere 10 and 30 times stronger than a porcelain veneered to metal. Okay, so it's with the right reduction in the right situation. So again, make sure you're doing your part here. Okay, so what else have you seen?
Well, we see a lot of contamination. I'm assuming this is moisture contamination. We'll pour up an impression and we get these little drags and pulls on it. Looks like,
Okay, so just so I make sure that I understand, you tell me if I'm wrong. Okay, so we take an impression, we take out, the time we look at it is, it's like our assistant looks at it and we go, did it look okay? Yeah, again, we don't even look at it most of the time. Okay, but when you pour it up though, now we're looking, instead of a negative impression, we're looking at a positive model of this, and we see areas that there was moisture, like a bubbled water on the side of it or something like that.
We know it's not tooth structure. It can't.
Yep.
Absolutely, yeah. And now we're to the point where, normally we just trim this off. But with these sensitive products, that's the lithium disilicon stuff,
right?
We're in doubt now. We're in jeopardy, if you will,
right.
And we see quite a bit of that.
Okay, let me make even another suggestion. Okay, when we're using coarse diamonds, when we do these things, and we're going to give you on an Emax 1.5, 1.2 millimeter axle reduction, we're going to have 2 at the top, 1.5 for the zirconium, and we just spray it off and we start to take the impression. I think that every office, it ought to be the standard of care that they take chlorhexidine, which is basically antibacterial, and scrub the tooth. Okay, now it removes the smear layer, but it also removes all the bacteria on it. I've done this impressions with and without it, and I can tell a difference when we pour up the models, whether or not it was just wiped off with a piece of a cotton pellet and chlorhexidine.
Right.
Okay. Now, drying it adequately is real important. Do you find that, and you may not be able to tell this looking, but I would think most of the impression materials you see are polyvinyls. PVS. Okay.
Very much so,
Okay.
yes.
Okay. And most people don't use polyether much anymore.
Not very much.
Okay. Now the problem with a polyvinyl siloxane is it begins setting the minute you mix it. Okay. You squirt too hard too fast, it'll leave a gummy situation in there.
Right.
If we pack it with the wrong cord, it has a different hemostatic solution there, it won't set up. And you'll notice it when you pour it up, but we might notice when we look at it.
Right.
And also if we use these little bitty micro tips and it comes out in little strings, oftentimes we'll go around the tooth and it's these little strings pile up on top of each other and create air bubbles. So when we take the final impression, have them bite together, it'll create that blob on the side of it. And the fix for that is just to cut the tip so it's a little wider. Make sure you go around it once, take air, blow it again so it pushes it down into the sulcus, then cover the whole tooth like a snow cone or an ice cream cone, then bite together with a heavy body. Okay, it should eliminate most of that. Okay, what else do you see?
The triple trays. Here's a relatively new technique, of course, in these little small plastic triple trays. A lot of times I believe these things can flex.
Sure.
And we'll see, for example, a 3-unit posterior bridge with a terminal abutment with 2 teeth. And even with a bite taken, I mean, it's a guess here. I mean, tilted this way, tilted mesiobuccally, and now we've got a huge problem when you go chairside. But yet we've done all we can do here with the limited materials that we've got. And I have a thing that I believe that these trays can actually flex. When as a patient bites down, and then when you take it out, it flexes back. So, then you'll get it back and I'll say, well, it didn't fit. Right. Well, it fits the model fine, and the model fits the old impression. So,
I know, but the logic for most doctors doesn't get that far.
Okay.
It didn't fit, it's your fault. Okay. Right. Well, and to the patient, it's always the lab messed up. Wasn't that
Right.
Now, let's back up just a second, because you kind of mentioned this. They have a 3-unit bridge, they take a single triple bite tray. Okay, look, I've got to say, if all you've got is one bicuspid up here, and you're trying to make a bridge fit in excursive movements, in other words, when they grit and go forward and backward, there's no way to do that without a full mouth impression. Okay, awesome. Can't be done. Okay, right. So if we're talking about a bridge, we need to do a full mouth impression. Now, secondly, we ought to limit the triple bite to maybe 1 or 2 individual units with at least a tooth between them.
I'd agree 100%.
Okay, good.
Absolutely.
Now, back to the triple tray, and let me just make this point. A lot of us take impressions before we start to make a temporary.
Right.
Okay. Now, I agree, we need to use something like clinician's choice, some type of very, you can't bend it by batting down it.
It's real rigid.
Right, real rigid. But even if you used one that was a tiny bit flexible, you need to take the impression for the temporary with the same kind of tray you're going to take for the final. Now, why? Okay, well, if I bite together, and they're not numb yet, they got together and they open, and we look at it, and we hold it up, and we can't see light through where the occlusion's down, the patient didn't bite right. Or we look, and that posterior extension, we can see it real clearly. In fact, it smushed all the impression material on it.
Right.
Tray didn't go back far enough, and it's going to cause the tray to flex.
Yeah, okay.
Okay, so the assistant can actually pick up on things like that, so that she can go, Doc, or they bite together, and like the side wings don't have any material, and they're kind of wedged out. You can't use a triple bite there.
Exactly.
You've got to realize that these are very tenuous at best and should be limited to maybe, and I've seen anterior ones where you could do a single tooth, or where you do a bicuspid and maybe the number 2 and make it work most of the time.
Mm-hmm.
But again, when we're talking about cuspid disclusion, we're talking about curvus V, we're talking about trying to mimic natural dentition where this side should match this side. I mean, we can't do it unless we have full.
That was going to be the next big thing.
Yeah.
We have the counter side to see, thus we can, like you say, get some excursion, get some protrusive, make sure that this crown's going to function properly, and the aesthetics. I mean, if I'm doing 6, I want the doctor to be able to capture 11.
Exactly.
I mean,
Yeah. Well, yeah, exactly. So, we normally born with 2 ears and 2
Right.
eyes, and if one ear's like huge and the other one's small, that really sets it off. And that tongue is so sensitive. So you take somebody that is a big bruxer. I mean, you can't see the linea alba. You can only see the wear and tear on the teeth. And if they've only taken a small picture by just a small area,
Right.
we can't see what's up. You have no idea
Absolutely.
what you're dealing with.
Absolutely.
So, what else has been going on?
Let's see. Marginal integrity is a huge problem as well.
Okay.
Just like you were talking about the zirconia and lithium disilicate, we needed that shaft or a good shoulder.
Yeah.
We see less and less of that now. A lot of times, the doctor will send the impression in with a feathered margin, an Emax or zirconia, and it's the prep. I mean, we're not in a PFM world anymore. We talked about that.
Yeah.
And
but even with PFM,
well, you shouldn't have that. That's right.
I mean, in a PFM, we're still. Can you get me an eraser? Because I'm gonna draw something and take it right off again. Okay. We start off with a bicuspid. Now we're sitting in between the teeth. So, okay, and so this is the. Oh, I've got red. Hang on just a second. The gum's here. The gum's here. Okay. Ideal prep is going to be a deep chamfer that follows the contours of the existing tooth. So we end up with something like that. If we were looking at it from the occlusal, we've got looking down on it. Again, there's going to be a definite finishing point all the way around when we look at this.
Yeah, and this should be about a millimeter and a half.
Right. Okay.
Right.
So this would be 1.5. This is going to be about 2 millimeters to 1.5, depending on what you're doing. Now, and again, ideally here, when we take an impression, we need to see about, ideally, a millimeter below the finishing line. Now, the only way you can do that is to pack cord. And X-Facil won't do it. It'll retract it a little bit, but you need to keep in mind too, doctors, that we no longer have to do subgingival margins.
That was what I was just thinking when you were saying that. I mean, there's no need to go sub-G anymore. You don't need to. If you get a good fit, if you give me that, I can put you a restoration on there that's at tissue level or even above. It's going to be sealed. It's not. I mean, you can't pull an Explorer. It's a great option here.
Well, actually, you've actually done a crown for me before, and I actually had a doctor that couldn't feel the margin with an Explorer.
That's what we
But
want, for sure.
I made the doctor who prepped it retake the impression twice because he didn't use cord the first time. And, well, it takes so much time. Or, again, my suggestion is we pack the cord before we even start the prep. And then once you've rinsed them off, you clean them with chlorhexidine, the cord is wet, you pull it, dry the tooth, squirt the impression material around there, air disperse it, add a little bit more, then if you're gonna use triple bite together on it. And again, one other important thing, and you may not even realize this, if I had you to, I said just like put your teeth together, and I said, okay, now bite hard. You just changed 30, 40, 50, 100 microns difference in how close your teeth are. Okay, now you take someone that's numb and they do that and they're not even sure if they're hitting.
Exactly.
Okay, so again, assistants, doctors, you need to remember this. You cannot put a triple bite in and walk out of the room. You have to have them closed, check it over here if you're doing it on this side, and then someone has to hold a hand under their chin, just like that, so they do not relax for the first couple of minutes. Okay, so real important to remember. Okay, can I wipe this off? Here we go. Great. Okay, what else is going on? I kind of put you on the spot here. This is probably every lab technician's dream. I get to kind of bitch and moan and tell people what I really think, and no repercussions here. But what else?
Okay, bites are a big thing here.
Okay.
And how to take bites. Here's my thoughts now.
Yeah, no,
I'm chairside. I'm just in the lab
yeah.
here.
No.
But I get a lot of doctors who will, put the mousse or silicone on the low. Let's say we're doing a 3-unit bridge, and they're doing an upper full arch and lower as well.
Sure.
And then they squirt the material and tell the patient to bite down.
Okay.
All right. Now this mouth is full of this
Goo. Yeah.
Of this goo.
Yeah.
And they say, okay, now, squirt it, they pop it out, throw it in the pan, and it comes to me. Now I'm looking at it, and it's been kind of dispersed. And is it accurate? And I'm thinking, there don't need to be that much material in the mouth because you need to see if these teeth are interdigitating. And how can you do that? You just need a little bit over the preps and a few teeth, and then watch the patient bite down.
Okay.
And once you do that, then you can verify that this bite that you're sending me is correct.
Right.
That's what, I mean,
And the bite registration doesn't make up for you not doing a full mouth. Okay, I mean,
No.
I mean, so
absolutely not.
No,
because when I've got the other mouth, then I can see how teeth interdigitate along with that bite. And of course, I'm not talking about just necessarily that, but even come up to here, but be able to verify that the people or the teeth are interdigitating properly.
Right. Exactly.
Without material, how can you do it?
Yeah, and again, I would use a bite registration material, not your regular impression material. It's heavier.
Exactly. Yeah.
It'll sit on top of the tooth, and keep in mind, he needs several teeth on each side of it, but doesn't have to be a full mouth, because when he gets it, he's actually going to take a scalpel and cut off all the excess material, so just he's interdigitated, because he's got to get the air bubbles off the models, and he's got to make sure it goes right perfectly on an articulator. What else?
I'll tell you something else that we see that, I don't know, you know about this, but adhesives on everything. I think just because a doctor a lot of time uses a perforated tray, sometimes they don't use adhesive. And I say personally that I'd use adhesive on everything.
Okay.
And we see sometimes I'll see the impressions coming out of the trays.
Right.
And I think that can be a big problem.
You think? Yeah.
I think so. Yes, sir.
Yeah. And you see triple bite trays. A lot of them will have lugs, locks, overhangs, and stuff like that. But sometimes it's still not enough. And again, if that separates, I mean, the idea behind having polyvinyl siloxane or polyether is that if it was done properly with the right tray, and used to be we used custom trays.
Right.
Okay. But with the right tray, we could make separate pours that were just as accurate as the first pour. You can't anymore with a triple tray and stuff.
Exactly.
You got to hit it right the first time, or it's not going to work.
Right.
Think of anything else there?
Custom trays are the way to go. We do them for a lot of our clients when they're doing removables.
Okay.
And of course, they don't do it with the fixed stuff.
Right.
And I'm not saying they're certainly necessary to do that. There's a lot of good systems out there. That Joseph, I can't think of the name of it. He's got probably an array of different trays. I was studying this past weekend. I can't remember his last name, so forgive me for that. But where you actually put them in heat them up in an ultrasonic and
they mold them.
Yeah, exactly.
To it. Yeah.
That works out really good. But the custom trays are really the way to go. Adhesives are huge. I mean, because if they could just use adhesives on everything, the triple trays, the perforated trays, you wouldn't believe the difference that it makes.
Cool.
So outside of that, prep design, and I think we've covered them.
Okay, so let me. I kind of jotted down a couple of things here, and have you ever? Surely you haven't, but have you ever had anybody send you an impression of a crown bridge that was made out of alginate?
You know what? I don't recall that, but let me just tell you one thing that I do recall.
Okay.
I had a case that came in. It was on a small plastic triple tray.
Okay.
And it was with the it was the Impergum material.
Okay.
And the impression was taken on the edge of the triple tray. I mean, the triple tray handle, it was on the edge of the triple tray.
Right.
I couldn't believe it. And I just thought, well, I don't think this doctor looked at this impression.
Right.
And I called him, and you know what he said?
Go ahead and fix it.
Do the best you can.
Do the best you can. Exactly.
Well, that's when you got to draw the line.
Right.
I said, we can't.
Well, I mean, I can say that. You shouldn't do that. No, but
yeah,
I mean,
that just goes to show you how important it is to at least see what's going, into the bag to send to the lab.
Okay, and let me see if I've got. We're going to clean the prep. We're going to use cord. We need a bite if we're going to do triple tray, and we're going to use a heavy bite registration. We've got to have a occlusal reduction at least 1.5.
At least, yes.
Okay.
Now, if it's a little less, and they want to put, some kind of a metal there or something, then we can, that'd be the only alternative here for that.
Okay. Oh, here's one, and I won't mention any names, but when you take, a triple tray or an impression originally was designed to have a light body and a heavy body placed at the same time. I know that I've had, when I was doing lab work, doctors send me, it was obvious that they tried to reline it, or they'd taken an initial impression and then squirted something and had them bite together again. I hate to say this, and this should seem like common sense to a doctor. You can't actually compress that without it rebounding. It's the hydrostatic pressure will distort the impression. It's never, ever, we're dealing in microns here, okay?
Sure, absolutely.
Never gonna fit, okay? So don't reline, do it at the same time. Oh, I saw this happen too. Delaminating impressions. The syringe material came loose from the, Now, that could either be relining it, or, and I saw this in a doctor's office, he was actually using the syringe material from one manufacturer and the heavier body or medium body from another manufacturer, and he took the impression at the same time. But polyvinyl siloxane is a very technical material that's hard to make, and there's differences in formulations, and you can't mix and match. You cannot mix and match.
Can't do it.
They won't stick together.
Exactly.
Okay. So anything else you want to?
The relines, like you were talking about, we see that pretty common. That's pretty common.
Oh gosh.
And it's kind of scary, and some, you obviously you can tell, but that's done quite a bit.
Okay.
Quite a bit.
Again, I'm thinking of multiple units. We're going to take a full mouth impression. I do think of one other thing. Polyvinyl siloxane works real good, but it begins to set the minute you start, use the auto tip.
Sure.
Okay. You have less than 2 minutes to get it in place.
Wow.
And the problem is this.
I actually thought you had a little more time.
No, you don't.
Wow.
And if it's still sticky, but now you stick another, the tray or push it in there, now it just smears and distorts. That will cause some of those pulls and tags that you see. Mm-hmm. So my suggestion, if you're doing more than, let's say you've got 4 or 5 anterior teeth, that's okay. You need to clip the tip so you can get it out quicker. You need to have people help you blow air on it so you can get it on there quickly. But if it takes you more than 2 minutes, you need to be doing something different material. And polyether is different in that it snap sets but you've got it through the whole working time. Polyether starts setting the minute it hits it, and you get even halfway through the working time and try to take the impression, you're going to get less than ideal results. So if I were going to take, you know, like a full mouth arch with 5 or 6 impressions and different sides of the mouth, I probably would use a polyether. Polyether is hydrophilic, you know, where it just has a lot of advantage. 99% of the thing I use the polyvinyl siloxane.
Sure.
But when I've got a lot of units to do in one impression, I'm using it because I got more working time on it, and it's a little bit more forgiving. So,
if you don't mind, I'm just like that. As far as packing cord,
yeah.
How much cord do you pack?
Okay. Ideally, I mean,
3.
Actually, 2.
That's ideal.
Actually, 2.
Okay,
I mean,
2.
I used, you know, maybe an O for the first one.
Okay.
And then look, and it depends too. I mean, if you had real healthy mouth like I have, where I floss every day and I suck on a toothpick all day long and stuff like that,
sure,
you'd be hard pressed to get 2 cords in there.
Right.
Okay, but for most people, you can easily get 2 cords in, and so you only pull one of them and leave one of them in place when you take the impression.
Right.
But if I could get doctors just to take a wider braided cord and just pack one, your life would be better.
Oh, absolutely.
Okay.
For sure. Yeah.
And again, I would delegate that to the assistant. It would be done before we even started prep. It's just, as I say, even if you make them supragenital, in other words, we're not below the gum, we still need the gum tissue away so we can see about 1 millimeter of the finish line.
Absolutely.
Then we know beyond a shadow of a doubt that that's where you intended that to finish.
Exactly.
And the emergence profile will be right, color will be better. So anyway, I think that does it.
Well, it's been
Okay,
appreciate it, Dr. Abernathy.
Okay, well, I want to get you back and talk about shading and stuff, but
Okay.
I think as far as preps and stuff, this we ought to go. Okay?
Good deal.
Thank you very much.